Hey, hello everyone and welcome. Before we begin, I'd like to take a moment to acknowledge the traditional territories of the Indigenous peoples across Canada. We are grateful to live, work, and learn on these lands, which have been home to Indigenous peoples for thousands of years. We recognize the enduring relationship between Indigenous peoples and their traditional territories, and the importance of honoring and respecting the histories, cultures, and contributions of all Indigenous peoples. My name is Michelle N. Goodfellow, and I'm the Communications and Engagement Manager for the PKD Foundation of Canada, which is the only national organization solely dedicated to fighting PKD through research, awareness and advocacy, and education and support. The format for tonight's event will be a roundtable conversation between nephrologist Dr. Matthew Lanktree and one of the directors from our board of directors, Henry Osei-Agyekum. The topic tonight will be the 2025 KDIGO ADPKD Guideline, the first ever guideline for the evaluation, management, and treatment of autosomal dominant polycystic kidney disease. The name KDIGO stands for Kidney Disease Improving Global Outcomes. It's an international nonprofit group that creates and shares guidelines to help doctors treat people with kidney disease. It's based in Belgium and is run by volunteers. Its goal is to help kidney patients and serve the public. This discussion, designed for PKD patients, their families, and healthcare providers, will provide an overview of the new ADPKD guideline and explain why it's important to both healthcare providers and patients. We'll be leaving time for a live question and answer session after the discussion, so feel free to leave your questions either in the Q&A area or in the chat throughout the presentation, and we'll try to address your questions at the end. This session is being recorded and will be available to view on our YouTube channel in the coming weeks. So I'll now introduce our panelists. Dr. Matt Lanktree is a clinician scientist, associate professor, and medical director of the McMaster Kidney Genetics Clinic, caring for patients with autosomal dominant polycystic kidney disease, chronic kidney disease, and kidney failure at St. Joseph Healthcare Hamilton and McMaster University. Matt trained across Ontario, starting with computer science at the University of Waterloo, medical school and a PhD in genetics at the University of Western Ontario, internal medicine and nephrology training at McMaster University, and a fellowship in inherited kidney disease at the University of Toronto with Dr. York Pei. Matt also had extra training in polycystic kidney disease at the University of Chicago with Dr. Arlene Chapman. In total, he has 17 years of university training. Matt has published over 100 articles in genetics and medicine and has received peer-reviewed funding from the Canadian Institutes of Health Research, the Canadian and American Societies of Nephrology, and was awarded the Canadian Society of Nephrology New Investigator Award. Matt cares for hundreds of patients with ADPKD, as well as patients with many other inherited kinds of kidney disease. And he set his goal to use genetics to improve the care of patients with kidney disease. And our other panelist is Henry Osei-Agyekum. He's the newest member of the PKD Foundation of Canada's Board of Directors. He has a degree in biochemistry and 15 years of experience working in the pharmaceutical sector. Having lost his mother to complications from polycystic kidney disease, Henry has experienced the impact of the disease firsthand, and he himself has PKD. With a deep personal connection to the cause, he's passionate about raising awareness, advocating for research, and supporting the efforts to improve treatment options for those affected by PKD. Henry's dedicated to making a meaningful difference in the fight to end PKD. So welcome, Matt and Henry. I'm going to hand over the floor to Henry now, who will be leading the discussion.
Thank you, Michelle. So we will, in the next hour, try to cover a broad range of topics from diagnosis and treatment to lifestyle, pregnancy, and long-term disease management. Matt, it's a pleasure to meet you, and thank you for being here today.
Thank you. Great to meet you as well.
So to start us off, can you help us understand why this new KDIGO ADPKD guideline is such a milestone? and what makes it important for both healthcare providers and then also for us patients?
Absolutely. First of all, I did want to say thank you for the opportunity to be here tonight, and thank you for everyone for joining us. And I hope you enjoy this kind of informal discussion. So hopefully we'll have some banter, and feel free to interrupt me at any time. But so as you heard in the introduction, KDIGO, or Kidney Disease Improving Global Outcomes, is really a group that's set out to try to standardize the care of people with all different kidney diseases. So not just polycystic kidney disease, or PKD, or autosomal dominant polycystic kidney disease, or ADPKD, but really all forms of kidney disease. So really the importance is it's a bedrock, it's a foundation, it's guidelines, it's an instruction book, or a recipe book for kidney doctors all around the globe to kind of use as a guiding light for the treatment of patients with polycystic kidney disease. Now, one of the important things, though, is that it's 900 pages. 900 pages, and there's over 250 recommendations. And so, it's the expectation is not that patients are reading through this document. It's really intended for providers. That said, absolutely, I encourage all my patients to educate themselves as much as possible about their disease. And so this document is freely available. It was published in Kidney International, which is the highest impact nephrology journal, as a supplement to that. And so you can get access to the actual document. If you're interested in delving into 900 pages, your Saturday night can be more exciting than mine. But the intention really is to help providers and to standardize care. Now, I do have to say that within those recommendations, there's a subset of those that are supported by better evidence. So as doctors, we try to make our decisions based on the research and the evidence that is out there. There's a tier, a structure to that evidence that comes from randomized controlled trials is the highest evidence. And so some of the recommendations within the KDIGO document are things that doctors really need to be following because they're supported by the best evidence. And then within the KDIGO as well, there's 250 points that are what we call practice points that are really suggestions. And it's important that patients know that, especially if they're going to go and read this document, because those practice points are really expert-based opinions. So there's suggestions and things that, we should be following, but oftentimes there's still nuances. There's challenges in implementing those points. There's regional variations across, again, because this is a global document. It's not just for Canadians, it's for the whole world. And so it's important that people understand there's that bit of nuance and context that's required when thinking about this document. Certainly, though, in the nutshell is that this is meant to be kind of a recipe book for those who care for patients and those learning to care for patients with PKD, to ensure they understand really the basis of the suggested care of people with PKD.
Thank you so much. Thanks for the clarification. Now, going back to basics, if let's say someone wants to get tested for PKD, what's the process? How would they get a referral? And what kind of tests should they expect?
So the initial testing for polycystic kidney disease is really just done with an ultrasound. And so a simple ultrasound, there's really no risk to it. It's just a probe on the abdomen where they look at the kidneys and look to see if there's cysts in it. In the context of a positive family history, so if one of the parents has polycystic kidney disease, then the presence of cysts in the kidney suggests that there is polycystic kidney disease in the patient. Now, there is a bit of nuance to that in that we know the cysts grow throughout life. And so if you're younger, you can not have cysts and maybe still develop it later. If you're older, if you only have one cyst, that may not mean that you have it, because if you're older, you should have lots of cysts, because the natural history, again, is that the kidneys grow and the cysts grow throughout life. So there is age-specific thresholds, and it is in the context of having a positive family history. So with that, I think it's important for me to talk about the difference. So everyone who has ADPKD, autosomal dominant polycystic kidney disease, has multiple cysts in their kidney. But not everyone with multiple cysts in their kidney has ADPKD. So that's a bit tough to get your head around. But everyone with ADPKD, which is the more severe form of the disease that really progresses, has lots of cysts in their kidneys and growth in their kidney size. But there are people who can have multiple cysts in their kidney, which sounds like polycystic kidneys, who don't have the classical ADPKD. And so I think that's important, that if people are looking at their own ultrasound report, it's important to talk to their physician about their clinical situation and not leap to conclusions, and really work with the doctor to help confirm the diagnosis. So there's a difference between screening, which is determining whether it's likelihood you have the disease, diagnosis, which is like being, okay, this is definitely what you have. And then the last part of this puzzle is prognosis. And so prognosis is how we think you're going to go into the future. So people that have relatively milder disease, which may be slower progressing, we may treat those people differently with different medications and different therapies than the people that have very severe disease. So again, these are nuances, and it's hard for people unfamiliar to necessarily grasp it all. Most people think that medical tests are black and white. They're yes and no. Either I have it or I don't. So that's why talking to your doctor about these kind of things is important, but screening is done with an ultrasound. And then diagnostic testing is really with the physician in the right clinical context. And sometimes we get to things like genetic testing, which we're probably going to talk about, or MRIs or CTs or additional tests to try to confirm the diagnosis. And then really prognosis is a whole nother question that I think we're going to get to.
Yeah, I was going to ask about genetic testing, which you already touched on. Should it be generally considered for ADPKD, and who benefits from it the most? Is it the patient? Does it help the doctor?
So it's a bit of it's been controversial, let's say, over the last 10 years, and really it's a moving target. The reality is that those three parts that I just talked about, screening, diagnosis, and prognosis, okay? So if you're in a situation where the diagnosis is unclear, so people who don't have a positive family history, that is the most common one. People that have unusual presentations. So say that they're, again, if a doctor is familiar with PKD, or the radiologist looks at the imaging and says there's multiple cysts, but we're not totally sure of the diagnosis. If people have rapid losses in kidney function that's not in line with the imaging, these kind of situations where we really want to be sure that we're dealing with ADPKD, that's the situation that genetic testing is really helpful. So it's not a black and white answer. To me, it's not that every patient with polycystic kidneys needs genetic testing. It's in situations, again, where we're not sure what the diagnosis is, because not everyone with multiple cysts has classic ADPKD, right? Now people say, oh, well, if genetics isn't the best, then I mean, certainly lots of people are familiar that PKD1 and PKD2 cause the majority of ADPKD, and those with PKD1 have the more severe form, and PKD2 have a milder form. So while that's generally true, and we look at lots of patients with PKD1 and PKD2, there's still substantial variability in how severe people can be, even with that mutation class. And even if you look at families that have the exact same variant causing their disease, there can still be significant variability in disease within the same family that have the same genetic variant leading to their disease. So what is the best for prognosis, or the other way of calling that is risk stratification, like saying like, how severe is my disease? Well, it's really imaging and decline in GFR. So as I said, the cysts grow, the kidney volume grows. And so with MRI, we look at how big the kidney is, and then we adjust for your age and your height, because, you know, tall people have bigger kidneys. So we adjust for age and height, and from that, we can come up with how severe your disease is. So using that, and then the other big thing, you know, if you're 50 years old and your kidney function is still normal, then you're going to have relatively milder disease than some other people with polycystic kidney disease who, by the time they're 50 years old, their kidney function by that GFR number, that glomerular filtration rate, that GFR number should be lower if you have a severe form of polycystic kidney disease by the time you're 50 years old. So that was a long answer to a short question. Who needs genetic testing? The take-home point is if it's in a clinical context where your doctor isn't sure of the diagnosis.
All right. One of the biggest concerns for most patients is disease progression, which you had already touched on. Could you explain how a doctor would determine how fast someone's PKD is progressing? And also, if you could share some light on what factors influence this.
Yeah, so that's a two huge questions. So let's start with the first one. So as I say, the best predictor we have, especially earlier in the disease course, is the degree of cyst burden in the kidneys. So Dr. Pei, my old supervisor, would say, oh, do the kidneys look like a bag full of marbles? So are they big kidneys that are full of those cysts? And how big are the kidneys adjusted for their age and height? So that led to the development of this thing called the Mayo classification. And so we use that and we look at, do people have what looks like a typical classical presentation, meaning both kidneys are evenly affected, or do they have an atypical presentation? We know people with unusual presentations actually have milder disease. Usually there's part of the kidney that looks kind of normal that is able to keep the kidneys working over time, whereas the more classical, even both kidneys totally affected, are relatively more severe. We then rank them from A to E. There's 5 categories, with A being the mildest and E being the most severe. And then the average age of kidney failure, you know, varies based on how big. So the bigger the kidney, the more likely the kidney function is going to deteriorate faster. So imaging is one. And then the other really important thing, so again, over the last 10 or 15 years, we've gotten better from estimating kidney function by this thing called GFR or eGFR, estimated glomerular filtration rate. So that takes your age and your sex and something called creatinine. So creatinine is a breakdown product of our muscles. It in itself is not toxic. It's released at a constant rate, and it's a water-soluble waste product. Why is that important? Because we filter it and we pee it out. If that creatinine doesn't get filtered out as well, it builds up in the blood, okay? So from that, we can estimate kidney function. Now, we've done this for many, many years, but the equations to estimate that kidney function, especially up in the more normal ranges of kidney function, has improved over time. So, you know, we can see that people with more severe forms of polycystic kidney disease, that eGFR number will decline in the neighborhood of 5 to 7 per year. Usually we start off between like 100 or 120, and kidney failure needing a treatment, you know, is below 15 and usually below 10. So you can see that going from 120 to 10, if you go down by 7 a year, versus milder people, it's usually more in the neighborhood of 3 per year. And the general population, that kidney function goes down about 1 per year. So, it goes now below 90 is stage 1, below 60, let me see if I got that right. No, 1 is still normal, 2, below 60 is 3, below 30 is 4, below 50 is 5, or below 15 is 5. So again, 90, 60, 30, 15 are kind of how that GFR number goes down throughout time. So we can look at the slope, or how that GFR is going down over the years. So again, the 2 big things are the decline in GFR over time and the imaging, how big the kidneys are and what the cysts look like. Now, one common question that goes is, oh, Dr. Lanktree, you last imaged my kidneys 5 years ago. How do you know how my disease is progressing if you haven't imaged it in the last 5 years? So the thing is that the vast majority of people, 80 or even 90% of people, will stay in the same risk category throughout life. So if we image you when you're 30 and you're a 1D, most people will stay a 1D forever. So even as their kidneys get larger, even if we give them therapies, they still stay in that kind of category. And if they do change, they only change 1. So from like D to C or E to D, they don't go from E to A. So, the need for imaging or repeat imaging is really in people that are on thresholds where it may change what we do. Now, that said, you may need imaging if you run into problems. You're having pain or stones or blood in your pee, worries of infections, things like that may lead us to do more imaging. But generally speaking, 1 MRI to determine the size and height and age adjustment, and then following that GFR over time is generally all that's required.
All right. Maybe one last question on diagnosis before we move on to the next topic. So many patients worry about their children inheriting the disease. Should children be tested? And what are the advantages and disadvantages of early screening?
For sure. So, if there is concern when the child is born, so, sometimes there's kids that have very large kidneys, have cysts that are seen even in utero, they have blood in their pee, or they have high blood pressure as a child. Those kind of situations, the child would be seen by a pediatric nephrologist, and they would be sorting it out. But that is a very unusual situation for ADPKD. The vast majority of kids with ADPKD will have no issues, no pain, no high blood pressure, they have no manifestations of it. And so really, at this point, in people with ADPKD, there isn't really a need for early intervention within the pediatric years. Certainly, you want to be waiting until children are, participating in the decisions for screening. There can certainly be challenges, psychological challenges, in telling someone that they're a carrier of a disease that is not yet even manifested in, life goals and all sorts of things. And it really shouldn't. It shouldn't. Kids shouldn't be told they can't do anything they want to do if they have PKD. And so it really goes to why test them, especially doing genetic testing in people that are asymptomatic. Really, I think you need to think long and hard and do lots of pre-test counseling and thinking about the potential ramifications before doing genetic testing in an asymptomatic person. Certainly, again, if they have blood in their pee, they have high blood pressure, if they're having pain or kidney stones or something like that, that would lead to imaging and may lead to earlier diagnosis. But as a whole, especially in children, the things that we want to encourage are the same things that I encourage for all children and all people of PKD or not. So generally speaking, the recommendations of doing, especially genetic screening for ADPKD in children, is that it's generally not needed or suggested. That said, there are situations where people really want to seek it out, and it is possible in those situations too.
All right. quick question from the audience. You had mentioned that, there would be cysts on the kidneys and sometimes the sizes would increase, etc. Do the cysts usually shrink after transplant or they remain?
So the cysts, the cysts remain in the kidneys for life. That's in a later chapter here that we talk a little bit about post-transplant situations. And a big question is whether to remove one or both kidneys. So generally speaking, the recommendation is to keep your own kidneys there as long as possible. If they have any, what we call residual kidney function, so even after you get a transplant, if your original kidneys are working even a little bit, people do better off. So we want to keep your kidneys as long as possible. Now, that said, if they're causing pain, if they have huge volume, if there's infections or stones or any of those kind of problems, that may lead to the decision to remove a kidney. Sometimes, at the time of transplant or after transplant, there's a desire to remove one of or even both of the kidneys. There can be a slight shrinkage in the kidneys post-transplant, but it is not, it's in the neighborhood of like 10 or 15% or something. Like it is not like they go down to, they are still large.
All right.
I'm just going to quickly jump in and say that there is one more question that pertains to this chapter that I think we can answer right now. And I know that the person asking is a healthcare professional. So they're saying, can we follow up with ultrasound or CT scans in place of MRI when diagnosing or monitoring?
So the downside to CT is it comes with radiation. And so, really we want to be having, we know that there's a lifetime accumulation and cancer risk of radiation exposures. And so we really want to have a good reason for doing CT scans, not just like screening in otherwise well people. So generally we want to avoid CT scans. And then the trouble is that it's really hard to correlate between ultrasound and MRI. If MRI is unavailable, there are situations where, like, if you have extremely large kidneys, so they're like 20 or 23 centimeter kidneys, we know they're high risk. And so the benefit of doing MRI over ultrasound in that situation is relatively less. So maybe ultrasound is all that is needed. Similarly, at the other extreme, where if the kidney is 10 centimeters on ultrasound, then they probably don't need an MRI because their kidneys are small. That said, there was older literature using kidney lengths of like 16 centimeters by ultrasound, but there's a lot of variability in ultrasound based on how the probe is placed and the positioning and who the tech is and radiologist. So we can really be fooled. So I really think in my opinion, everybody, especially where there's concern of moderate to high risk ADPKD, should have an MRI at some point. At the same time, I think that there's low yield in serial MRIs or multiple MRIs unless there's complications. And similarly, I don't think there's a real need for serial ultrasounds, again, unless there's a concern of a complication. Certainly you can see stones or hydronephrosis, which is like a blockage on ultrasound. So those would be reasons to do it, but I don't think there's a need for, serial ultrasounds.
All right. Moving on to kidney manifestations. You talked about GFR, and we all recognize that blood pressure management is also critical. How often should patients have their blood pressure checked? And also, how often should we check our GFR?
So blood pressure measurement, the big thing here is that, the reality is the lower the better. Specific targets vary depending on how severe your disease is. There's been a lot of extrapolation in the KDIGO guidelines, the suggestions that are based upon a big study called the SPRINT study, which was a study of, lots and lots and lots of people, that not just people with polycystic kidney disease, but the reality is that the important thing is to be on medications that make people live longer and generally lower blood pressure to the point that they don't create side effects or adverse events. So That said, the best way to measure blood pressure is not in your doctor's office, but actually at home. Because what I care about is not what your blood pressure is after you just, fought traffic and then couldn't find parking and then you're coming to see your doctor and you're nervous to see them. That's not the blood pressure. Everyone's blood pressure goes up when they're excited. Everyone's blood pressure goes up when they're climbing stairs or running on a treadmill. What I care about is what your blood pressure is like on Tuesday night when you're watching Friends on the couch. So, or whatever, your TV, your Netflix. So, ideally people are checking their blood pressure, once a month, twice a month. It doesn't have to happen that regularly. You want both feet flat on the floor. You want your cuff at heart level. Take it once, ignore it, take it again, take it again, take it again. Track your own blood pressures yourself. I want you to have the power as the patient to be like, this is where it's at and this is where I want it to be. Again, you can talk with your doctor about what's the best specific threshold or target for you. Whether it's as low as 110 on 70 or 120 on 80 or 130 on 90. Certainly, the lower the better. At the same time, we don't want people being lightheaded. We don't want people falling or, running into complications of low blood pressure either. And again, having those measurements at home where you are convinced that you've got it as low as you can get the machine to get it and how you feel at that situation. And then if you come into clinic and say, oh, Dr. Lanktree, I think we should work harder to make it a little bit lower, then we can talk about one of the many options we have to try to lower blood pressure. So that's another thing. There's many classes and then there's many choices within those classes. So there's a whole gamut of options that all have their own pros and cons. And so talking to your doctor about which one is the best one to try to get that blood pressure where you're happy with it. And I mean, I can tell you the pros and cons of it, but really I like patients to be driving where they want their blood pressure to be. In addition to keeping that blood, so if you log it over time, the kidneys control blood pressure. It's not the heart, it's not the blood vessels, it's the kidneys. All the salts, the water, the hormones that control blood pressure come from the kidneys. And so you have kidney disease. If you have cysts in your kidneys, that leads to high blood pressure. There's no amount of Doritos you can avoid or dietary things. You will get high blood pressure if you have polycystic kidney disease. And so you are going to need, it's not like a personal failing or something like that. You need to work with doctors to help to manage the disease that you got that is bad luck. And yeah. So monitoring it over time, tracking it, put it in your phone in the notes section. The other thing I would encourage people to put in addition to blood pressure is their heart rate and their weight. So weight is another vital sign. We need to be tracking it over time. The only way that we can improve things and target things is if we measure them, right? And so really keeping an eye, I would encourage everyone to have a scale and a blood pressure cuff, and it should not take over your life. It shouldn't be a cause of stress. It's just once, a month or twice a month that we kind of keep an eye on that ourselves and keep ourselves accountable.
All right, that's a very good point. So for patients beyond cyst growth, are there other symptoms that we should be watching out for?
So I talked about it. Most of polycystic kidney disease is relatively asymptomatic. Now that said, it's super common to have pain. Pain can range from either acute flares in the context of like stones or infections, cyst ruptures. So those are acute events that are more severe. Thankfully, most of those events are self-limiting, usually last a few days. In contrast, the kind of dull ache that I hear is common. I hear it routinely that people will have flank discomfort or in the context of trauma, like if they get hit on their kidney or something like that. So kind of chronic discomfort. And really, it can be really stubborn and difficult, and I really empathize for people that are dealing with that because there's not a lot of great therapies for that kind of pain situation, especially as the kidneys get larger. When patients are younger or their kidneys are smaller, oftentimes they're relatively asymptomatic, except for if they run into one of those complications.
Okay. We'll move from kidney manifestations to management and progression of the disease. A lot of people hear about kidney transplants, and they are told that they have to wait until their GFR drops maybe below 15 or 13 or 10, sorry. What's the reasoning behind this? And is there any preemptive transplantation an option? Is that something that someone could consider?
Yeah. The reality is that kidney transplants, on average, so a deceased donor kidney transplant, on average, only lasts 10 years. Now, a living donor transplant in someone with polycystic kidney disease who takes their immune suppression medications, they can last 30 or 40 years. So in an optimal situation, those kidney transplants can last a long time, but the median, is shorter than that. Sometimes people need 2 or even 3 transplants to live a normal life expectancy. So the reality is that the longer we can delay the first kidney transplant, the longer we can go. And, getting a kidney transplant isn't, it's the best intervention in modern medicine, but it still comes with challenges, right? Like you still need immune suppression medication, it's still a surgery. So, we really want to keep your kidneys, your original kidneys, working as long as possible. So generally speaking, we suggest people wait until that GFR is around 15 and then start the evaluation. If you start the evaluation for transplant too early, then you just have to redo the evaluation when you get closer to actually needing it. So the evaluation is ruling out cancers, ruling out heart disease, making sure your anatomy is okay, that kind of thing. And similarly for the donor, we can't evaluate the donor and then get the kidney 5 years later. So it doesn't make sense to prepare too early. We want to be waiting till when it's needed. And we want to keep your kidneys as long as possible.
Okay. I have a question on patients who are currently taking tolvaptan. They're doing everything right. They're following a strict diet, but they're still seeing a rapid decline. What should they expect? And does that mean that dialysis is inevitable?
So tolvaptan, the only cis-directed therapy in polycystic kidney disease. It is the only disease-specific therapy that's currently approved. There's multiple therapies that are still under investigation, and so we can still hope for more in the future, but currently the only cis-directed therapy we have is tolvaptan. But that said, it is not a silver bullet. It slows progression of the disease by 20 to 30%. So I had mentioned earlier a 7 per year or a 3 per year. So, even if there's a 30% reduction, that still means you're going from like 7 to 5 or 4 per year. So it is not a silver bullet. It does not get rid of the disease. And you can say, oh, a difference of 3, that's no big deal, but that compounds over time. So that's why recognizing the disease early, starting the disease early, we have long studies now to show that the benefit of the disease continues year after year after year. If you're on the therapy for a longer period of time, every year you're gaining that benefit. So don't get discouraged if that GFR continues to decline on therapy, because that is the expectation. It does not get rid of the disease. The disease is still there. And then people say, well, how do I know it's working? If my GFR is still going down on, people can get discouraged and say, why am I doing this? It's still getting worse regardless. And I understand that is tough. I can show you the big studies with thousands of people where half of them got it and half of them didn't, and the outcomes were better in the people who got the medication than the people who didn't. But then people say, well, what if I'm a non-responder, or what if I didn't? So, I think talking to your doctor about making sure you're getting an adequate dose and that, your urine is adequately dilute and those kind of things, making sure that you're not suffering from any complications, all those kind of things to talk about. But still, if you have ADPKD and you have progressive disease, the best thing that we can offer really is multidisciplinary care, making sure you're doing all the things. And importantly, tolvaptan is one, but it really has to go in the bigger complex, the bigger picture, right? So, you got to be fit, lean, and active. We need people exercising. We need you to be as fit and lean as you can be. Not smoking is vital. That blood pressure we've already talked about has to be optimally controlled. Smoking of anything is really a big no-no. So ensuring that you're getting all your ducks in a row and doing everything you can to optimize your situation. But unfortunately, even people that do absolutely everything right, the reality is that some people have severe disease that is going to progress even with all optimal therapies. As I've already said, the more we can delay the onset of kidney failure and the time at transplant, the better. Ideally, kids are out of the house. If you have kids, you're into retirement age. Getting a kidney transplant when you're 70 is not the same as getting one when you're 50, right? So the longer we can delay the need for that, the better. And so people need to stay positive and stick with it.
We are with a few questions from the audience. At what EGFR should tolvaptan be stopped?
So there are studies. So the big randomized control trials enrolled people down to a GFR of 25, but then continued people on therapy into the studies. Okay, so it's below 25. There have been observational studies that have evaluated people all the way down to on transplant at the time of transplant. Because tolvaptan causes a diuresis or makes you pee a lot. Anyone on it knows that you pee a lot and you need to drink a lot. If you stop tolvaptan, sometimes there's a little bit of an increase in that EGFR. So personally, I continue people on right up until we're approaching the time of dialysis or transplant. And then we stop, hoping that maybe there's another month or two, maybe that GFR number will get a little bit better. But really continuing almost until the time of dialysis or transplant.
Okay. Another one is asking whether sclerotherapy for larger cysts can help delay progression.
We don't have evidence of that as of yet. It's challenging because, as I said, one of the best measures we have of disease severity is kidney volume. And if we put a needle in and remove a cyst and then make it scar down, then we have reduced kidney volume. But we don't actually know that that slowed progression to kidney failure. So the current recommendations are really that sclerotherapy should be for people with dominant large cysts. So if you have a bag full of marbles, there's no one cyst that we can target. You could go all over the place and not really change the kidney volume. If there's a cyst, a dominant 5, 8, 10 centimeter, even 20 centimeter cysts that are providing discomfort or pain, and the patient can say, look, right here, I can feel right here a softball. And the ultrasound in the right situation with a provider, so it's interventional radiologists who need to be comfortable with the procedure, can see with an ultrasound probe and put a needle in it and drain that large dominant cyst, especially if it's symptomatic. And then there is different ways that radiologists, and again, there is practice variability across Canada and globally in how these are managed. There are sclerosing or scarring agents that can be put in the cysts to try to prevent the cyst from recurring. Because we know if you just drain it and then take the needle out, it just fills back up with fluid and returns.
Okay, so we'll move on to polycystic liver disease. If someone has ADPKD, do they have a chance of developing PLD as well? And how is PLD diagnosed? And let me add also another one. Does the management for PLD differ from the management of ADPKD?
Yeah, so great question. Polycystic liver disease. So right off the top, there's a whole chapter in the ADPKD or the KDIGO guidelines on polycystic liver disease, even though it's written by kidney doctors. So there are hepatologists who manage people with liver disease. That's a liver disease specialist is called a hepatologist. It's a subspecialty of gastroenterology or GI. But that said, because there is overlap, lots of nephrologists or kidney doctors who take care of people with ADPKD are familiar with ADPLD. Now, the vast majority, 80–90% of people with polycystic kidney disease will also have cysts in their liver. Usually this is, a few scattered cysts that causes no problems. Rarely there are people with polycystic kidney disease, and they're not even necessarily correlated. So you can have people with relatively mild polycystic kidney disease who can have very severe polycystic liver disease. So both the organomegaly, or the big organs of the kidney and liver, can grow and become very symptomatic. And really, so treating polycystic kidney disease, there is also isolated polycystic liver disease, which is a different disease altogether. So those people have cysts in the liver and have no cysts in their kidneys. There are therapies. So both sclerotherapy is a possibility. Somatostatin analogs, there's an injectable medication, but really severe cases of polycystic liver disease and kidney disease should have a multidisciplinary team, including a kidney doctor and a liver doctor, to evaluate if a therapy for the liver is required as well. So there's a different injectable medication. There are some other nuances. There are interventional procedures, partial hepatectomy, so taking out part of the liver. The liver function is maintained. So unlike polycystic kidneys, where the kidney function gets worse as the cysts grow, the liver has more redundancy. And so even as the cysts grow in the liver typically continues to work. Yeah. One thing I would say is that it's much more often that women are affected with polycystic livers than men. It's about 4 or 5 to 1. So the polycystic liver is more common. We don't totally understand why that is the case. The hypothesis, or the suggestion, the guess, is that there's something to do with estrogen that controls the liver cysts that is not present in men. And so there's a suggestion, to avoid estrogen-containing oral contraceptive pills in people with severe polycystic livers. So there are many women with polycystic kidney disease that do fine with oral contraceptives, but in the context of polycystic liver, the recommendation is to avoid oral contraceptive with estrogen-containing therapies in those people.
All right. Someone had a question on that, so I think your last point addresses that question. Managing the disease beyond medical treatment, I think also involves lifestyle choices, physical activity, etc. So in the next 12 minutes, we'll try and discuss things around lifestyle and psychosocial support. If someone wants to see a nutritionist about managing their PKD, can they access this to the help of their nephrologist, or would they need to get this out of pocket?
So the nutritional, it really varies depending on where you are in Canada and what type of specialist and clinic. Thankfully, especially in people that are on tolvaptan, it's easier to gain access to a nutritionist because there are, so salt intake and protein intake really dictate the tolerability of tolvaptan. The more salt and protein you eat, the more pee you make. And so access to a nutritionist or dietitian can be helpful in the context of people on tolvaptan. People with advanced kidney disease, so once your GFR is between 15 and 30, may get access to a dietitian through something called multidisciplinary care kidney clinics, or MCKC clinics, that are common in Ontario. But again, that's going to vary by province and jurisdiction, and certainly globally. So you really will need to ask your provider if there's a nutritionist or dietitian available to you. That said, the Canadian Food Guide, so they just updated the Canadian Food Guide. I would really recommend everybody to look at it. It's not specific to polycystic kidney disease, but everything they say is good for people with polycystic kidney disease, especially earlier in their course of disease. So, limiting simple sugars, limiting, any sugar containing beverage, thinking about, the breakdowns of the proteins and carbohydrates, having high intake of vegetables in particular. And so the Canada Food Guide has been updated and is excellent. And we know that people with obesity have more challenges in polycystic kidney disease. They have more pain events, they have more rapid progression, they have more trouble getting transplants. And so staying fit, lean, and active is essential.
All right. Last question on lifestyle. There's a confusion around hydration. What's the best water intake recommendations for ADPKD patients, and also whether we should avoid caffeine and things like that. So what would be your recommendation on this?
So caffeine is something that has been suggested, and they have tested it in animal or models and things, but really we don't know. I wouldn't suggest high levels of caffeine, but I think having a coffee a day, like a reasonable amount of caffeine intake is probably okay. So I wouldn't go overboard in one direction or the other, but like most things in life, moderation is typically hard to sell. As for water intake, so certainly people with high-risk disease on tolvaptan are going to be thirsty. And people usually pee in the neighborhood of 4 to 6 liters a day on those types of therapy, and even more. So how much you pee is how much you need to drink. So you get an idea of the water intake of people on tolvaptan. People that have moderate or high-risk disease, we really try to encourage them to take 3 liters a day. It lowers the risk of kidney stones. Tolvaptan works by blocking a hormone that's sent out by the brain to the kidney to hold on to water. So that hormone is a growth factor. And if you drink lots of water, then there's less of that hormone sent. Okay, so that's the kind of rationale that we should be getting people to drink as much as they can. The highest level evidence, the randomized trial type evidence, isn't really there for promoting high water intake. It's still probably a good idea to prevent kidney stones. Theoretically, it makes a lot of sense, and it gets people ready for if they were going to try tolvaptan. So certainly trying to target like 3 liters a day is probably a good idea. That said, no one is going to drink 3 liters based on thirst. So you really need to have like water bottles and try to have set goals. And then that's really tough to stick with. So even in the best studies, there was an Australian study where they randomized to counseled water intake. People really had trouble adhering to drinking that much water. So I think it's a false goal for me to try to tell people to drink 4 liters a day, because they're not going to be able to do it.
All right. I have a question for ADPKD and pregnancy. Are there increased risks for pregnancy in someone with ADPKD? And if there are, what precautions should they take?
So there is, and it is a good idea. It's going to vary depending on your stage of disease and how severe. So really talking to your doctor about it is the best thing. So women with more severe disease are going to be at higher risk of things like preeclampsia, so high blood pressure or protein in the urine during pregnancy. Women with milder disease are going to be at lower risk. Speaking to your doctor about whether like taking aspirin during pregnancy, in women with higher risk of eclampsia, there is evidence for aspirin. And then there are clinics. So for instance, in my center, one of my colleagues, Dr. Matthew, is an expert in treating women with kidney disease during pregnancy. And there are clinics like that all across Canada. So women during the conception or pregnancy part of their disease should consider seeing someone with expertise, particularly in that. There is mention in the KDIGO document, if you read into that, there are some fancy new tests to try to measure for early stages of preeclampsia. And I can tell you that's one of those situations where there's a suggestion to do it, but there is variability in access to that kind of new testing. So again, I would suggest that especially in higher risk patients, referral to someone who's familiar with the situation is a good idea.
All right. For the sake of time, we have to wrap up. We've covered a broad range of topics tonight, from diagnosis and treatment to long-term disease management. But before we wrap this up, Matt, is there one key takeaway that you'd like to leave our audience with about the KDIGO guideline?
I want to thank again everyone for being here, and Henry and Michelle for organizing everything. People often make fun of me that I could talk about PKD till I'm blue in the face. It really is the joy. One of the joys of my career is helping people through polycystic kidney disease. It's really bad. It's just bad luck. And so anything I can do to help people, really gives me satisfaction. People need to really, try to stay optimistic and take their own health into their own hands. So as I said, find things that you love to do to keep you fit and active with friends and family that give you joy. So be fit, lean, and active. Keeping an eye yourself on your weight and blood pressure and setting goals for yourself, and then working with your doctor to make sure that you're meeting those goals. Not smoking. And those are really the big keys. There's no reason that someone with polycystic kidney disease shouldn't have the same life goals as anybody else.
Well, thank you so much, Matt, for your time and for your expertise. And thank you to the audience for joining us. I'll hand it over to Michelle.
Awesome. Thank you, Henry. I'd just like to mention to the people who are still on the call that there were a few questions, again, from a healthcare provider in the Q&A area earlier in the session, and they were sort of enough of a medical technical nature. Dr. Matt, if I can forward those questions to you to sort of have a quick answer that we can email out, would that be
Definitely.
something that you
or
can
even
do?
I'd be happy to speak on the phone too, if that would be easy.
Okay. All right. Well, we'll make that connection if we can do that. And if no one else has any questions, we will be wrapping up. So thank you to Matt and to Henry. The video of this session will be available on our YouTube channel in the coming weeks, and all the registrants will receive an email once the video is available, if you want to watch it again or if you want to share it. If you have additional questions that you would like us to ask specialists like Dr. Lanktree, please feel free to email us anytime at endpkd@endpkd.ca. And I've put a lot of links and our email address in the chat right now. So I'd like to thank you all for joining us today. And if you are curious to learn more about some of the KDIGO ADPKD guideline information, there are a number of infographics, so sort of summarized points from each of the chapters with some nice graphics that help explain them. And we have been talking about them on our online community, My PKD, all month for Kidney Month. And if you would like to join My PKD, it's a private confidential online space for people affected by PKD. You can see a lot more about the ADPKD guideline. So thank you, everyone, and have a good night.